Production support for this episode of In Focus is provided by Hoosier Energy, providing electricity to Central and Southern Indiana electric cooperatives and their member customers. Information at hepn.com. Beltrace, providing a variety of residential options, including independent and assisted living and complete health care for seniors through every stage of life. Beltrace, exceptional care, extraordinary caring. And by WTIU members. Thank you.
We've all heard stories about seniors spending their entire life savings and even losing their homes to pay for care late in life. Long-term care facilities can cost upwards of $200 a day. There seems to be agreement that people would rather stay in their homes and live independently as long as possible. But assistance is difficult to come by, and people can spend months on waiting lists. We'll look at the cost and benefits long-term care can bring to the elderly and their families on this episode of In Focus. Thanks for joining us for this edition of In Focus. I'm Sarah Whitmire. The fastest growing population in Indiana is people who are 85 and older. More than 115,000 Hoosiers fit into that age bracket. As WTIU's Gretchen Frazee reports, the cost of aging can be high, and getting loved ones the care they need and want can sometimes be difficult.
As more people age, there's more of a demand for services. How to pay for care becomes a complicated question. There's long-term health insurance, Medicare, Medicaid, self-pay. In Indiana, the state offers assistance to eligible seniors in the form of a program called CHOICE. The acronym stands for Indiana's Community and Home Options to Institutional Care for the Elderly and Disabled. The program provides in-home services, but the waiting list is about 5,000.
If people are on a waiting list to get those services, to get those choice dollars, how many of them actually are going to still be here and live to see getting onto the list?
Cora Lucas works to provide food, care, and help with basic everyday needs to seniors who live in Jackson County. She participated in a rally at the State House this week with dozens of seniors who want to see the legislature allocate more money for community-based services.
Funding has to continue, and with the growing population of the baby boomers, of course we're going to need increased funding. And if budgets are being cut or not increased for the demand, how are we going to meet the needs?
The solution is sometimes to abandon the waiting list and instead enter a nursing home.
I mean, there are a number of people who could remain in the community if they got 4 hours of care in the morning and a couple hours in the evening.
Medicaid is required to pay for long-term care, but IUPUI professor Kathleen Unroe, who studies nursing homes, says even that gets complicated. The services don't kick in until a person's assets are depleted.
To pay the daily cost of a nursing home will eat through someone's savings pretty quickly. If they don't have other insurance coverage to take care of it, or to help out with that, or long-term care insurance coverage, which most people do not have, or they don't have family that can pay that bill, then their savings will be spent down pretty quickly. Someone spends down to eligibility to Medicaid.
Nursing home costs can range from $5,000 to $12,000 a month, depending on the amount of service needed. Ways and Means Chairman Representative Tim Brown says the solution to providing seniors with quality care is like a three-legged stool.
You have to have the long-term care insurance. You have to have maybe some screening eligibility guidelines as you go forward, and then you have to have family and your own self-pay as a part of that.
If any leg of that stool is broken, the whole thing is at risk of collapsing.
As they prepare and they save their whole entire life, it should be for what you need. It shouldn't necessarily be that I'm saving to pass something on to my family. It should be for the care that I need, and therefore not give away assets just because I have the assets to give away.
Crothersville resident James Daly considers himself lucky. He has long-term health care insurance that can help cover his expenses if he needs to eventually be placed in a facility. And he has 3 daughters.
And I say, whenever things go wrong, put me in there, but let me stay out if I can do things by myself as long as I can, and reasonable and knowledgeable about what's best for me. Let me stay home if I can.
We're joined in studio tonight by Ginger Fitzpatrick, the Health Facility Administrator for American Senior Communities, Sharon Spencer, Columbus Regional Health's Clinical Case Manager, and Arif Nazir, an Assistant Professor at the IU School of Medicine in the Division of Geriatrics. Thanks to all of you for being here tonight. I want to get the conversation going by just talking about how the role of nursing homes has changed, say, over the past couple of decades. You want to get us started?
Sure. Well, Sarah, I've been doing this over 30 years, so I've been privileged to watch and be a part of how the changes happened. And I would tell you that the role of nursing homes has expanded significantly for being a focus and a home for people who were disabled and had no other options in life, to being very focused on rehabilitation. The nursing homes today can provide and do provide lots of avenues and venues for residents to come in, rehabilitate, and go home. They are as big a supporter of that as any other program out there, and that is primarily how I've seen them change, to focus that direction, to help people be independent and return to their homes. And often we have people who will come to us for rehab maybe 2 or 3 times before they're ever at a point where they need to stay for long-term care. So that's a very good advent of the process that has happened through the years.
I think that runs counter to what a lot of people think, though.
Oh, definitely.
Nursing homes are for long-term care.
Long-term, where you go to die. Once I get in there, I'm never going to get out. And that I place people in facilities almost on a daily basis with the primary focus of short-term, get you stronger, get you back home, give the family a chance to come up with a plan on how to keep you home.
Yes, and I agree. I think these concepts have changed significantly over the last 2 or 3 decades. And nursing homes, if you look at their history, show us that over the years, nursing homes have been very, have often morphed to meet up the needs of the society. And this is what we are seeing, that nursing homes, again, if you will, risen to the occasion to help our frail elders who go to the hospital and are not ready to go home, and have risen to the occasion to really provide high acute care for them. Because without those services, we see that there's nobody at home to provide that care. So I think nursing homes have done well in terms of providing those resources. But what nursing homes, in terms of the resources they have, that is the question. Sometimes not all the nursing homes are ready to provide these kind of two-pronged care. On one end, they have to provide care to these long-stay residents who are there for the residents who are going to be there because that's their home. But on the other end, they have to provide a total shift in philosophy kind of care, which is very acute in nature, pretty much similar to what our hospital used to provide a few years back. So I don't think a lot of people realize that how significantly nursing homes had to change as a requirement of the society for that.
I agree, Doctor, and I believe that our rehab units and long-term care facilities today, and I have a pretty extensive background in that, are very much what the rehab units were in the hospital a number of years ago, where the hospitals have moved away from that, more to diagnostics and then laying out a treatment plan that people come to long-term care. And we're not just talking geriatrics. We have had our fair share of hip, knee replacements, people that are younger than I am, that have come into rehab for periods of time, 20 days, 4 weeks, depending on what they have. But when they leave us, then they have a better opportunity of being successful at home. And the recidivism rate back to the hospital and readmission is much lower. And that's a tremendous savings to the healthcare dollar. The cost of care.
And I would like to specify on that, on some disorder, overall I would say there has been the help, but nursing homes for specific disorder like heart failure or COPD, unfortunately, patients who come to rehab may not do as well. So we have room for improvement on there. And just going back to this trend that nursing homes have evolved over the last few decades, I would say that one thing that may have done is put a lot of pressure on nursing homes to provide high volume care to these short-term rehab patients, which is quite intensive, which may have led to some less focus on care of residents who are there for long-term stay. So really the nursing homes have been asked to provide these 2 different kind of cares, which are really on the 2 extremes, I would say, right? On one side, there's a frail resident who's 89 years old with dementia, where family wants to just provide comfort care and supportive care, while on the same floor, on the other end of the nursing home building, you may have somebody who is 69 years old, very robust, who recently had heart disease and is in the hospital, in the nursing home just to recover from their episode. So I think that has led to some new issues that nursing homes had to face, and also definitely have led to higher costs for nursing homes.
Absolutely.
I want to ask, this shift in who we're serving more in nursing homes now, how has this contributed to just the quality of care people are getting in nursing homes? The 2011 survey by the AARP showed that Indiana ranked 47th out of 50 states and for a number of criteria, but overall based on quality and access to care. So are we not shifting over to serving this new group well? Or
I think one thing we have to do is also to know our scoring systems. As I would say that these scoring systems are based on minimum data set measures. Minimum data set is a database of indicators on these residents. It has more than 400 items. This was really introduced in the early 1990s based on the Omnibus Budget Reconciliation Act, which stated that patients' care should be evaluated and should be gauged. Well, that worked really well for the population in the 1990s, but are those scorecards still valid for a population which a nursing home is caring for, which could be really a population which we considered as acute care population from 10, 15 years ago?
Right.
So I think basing all of our assessment based on just scoring card systems at this time would not be the right thing to do, but of course the scorecards do have a role to play to some extent. And I agree that Indiana has some room for improvement when you look at the scorecard measures overall.
I would agree with you, Doctor. And again, it is slanted by the acuity of many of the targets that are looked at in that data. And when the acuity is incredibly high, it does skew that data to not be necessarily what it truly is.
And really the federal government is trying to work on that because their new scorecards, which is a 5-star rating, which is every nursing home in this country is rated, which is a part of Medicare program, is rated on the Nursing Home Compare website. And you can Google it and find it right there on the top, Nursing Home Compare, and you can put your zip code and find where the nursing home ranks. So the federal government is changing their scorecard to make it a little bit more conducive to the fact that the nursing home, a lot of nursing home patients may be a different population than they used to be 20 years ago. So there has been some adjustment in that.
And it's very rare that we place a patient these days with the idea of them going there to live.
Correct.
It happens maybe 1 out of 15 patients that I happen to place. So the mindset for the families when they are looking at the care that their loved ones receiving may not be at the same point when they're doing their surveys. Exactly,
and in the same, I will just extend that, a very good argument, is that, you know, when we talk to families about choosing a nursing home, 30 years ago it used to be for selecting a home, basically. So things like closeness to their relative's home, how far is the pastor, how far is your favorite hairdresser, used to be important, but now patients enter the nursing home through a different route. They're really coming for a short-term rehab purpose. And it's really important for us to educate, as educators, to tell them, inform them that what their purpose of a nursing home stay is. If it's going to be for long-term purposes, then those factors are important. But if it's really for short-term purposes, then they really need to do their homework and find out which facility will be able to provide the real acute care they need. Could be heart failure care, could be wound care, and I think we have our job cut out for us to educate the residents and the families that nursing homes are changing and they provide a lot more different services than they ever used to before.
I want to touch on something one of your colleagues said in the story we heard at the beginning of the show, where she said we have a lot of people who are in nursing homes who wouldn't have to be if they could get services at home. The figure I saw was something like 4,000 or 4,200 people perhaps. So is there a shortage of that kind of care in Indiana? Are we seeing people, I mean, are you sending people to nursing homes perhaps recommending that?
I am doing that because of the fact that I cannot get services for them that's affordable. Many people do not plan for the future. They cannot afford to pay for 24-hour care in the home, nor can their family. To ask for any assistance through the area agencies is going to take anywhere from 6 months to 2 to 3 years, depending on which program they're looking for. And many people are going to fail before that's available. So if we are evaluating them, we determine that there's not going to be a resource for them at home, and the safest place for them for that period of time would be in the nursing home, then that's what we're going to recommend.
And the important thing to see here is that I know we're doing this, but if you really compare the cost for a nursing home stay for a month, you could be spending up to $6,000 to $7,000 a month. But if you can really provide some resources for these residents to stay home with some paid services available to them, it would be a lot less than that. And actually, a lot of states have tried those programs, and we have some programs for which we have a big wait time. I would definitely like to mention a program called the PACE program, which a lot of states have instituted, that with extra help, they are able to keep their patients in homes. If not, they will be really in nursing homes. So, so I think there is some room in Indiana where a lot of residents could benefit from being in the community rather than being in nursing homes.
We all agree, and I think when you look at the nursing home and you look at the cost of home care and you look at the nursing home, if you're at a nursing home and say your cost for a month is $6,000, you're looking at less than $10 an hour. And to acquire that kind of care, services, financial support outside of the nursing home, if you have a family member who are you living with, or you're living in an environment where you have people to take care of a lot of your basic things, those other services certainly could support them. But one of the problems is if they don't have that, and if there's a fire in the home and they're not able to get out, or if they have, or they're declining, then those are the people that become the long-term care
Absolutely. There's a group of people who, because of their cognitive impairment or their functional limitations, will not survive or do well outside the environment. But there is a group of people who would benefit from, in terms of big one is life quality. I mean, of course, no matter what kind of a nursing home environment you can create for our older seniors, they would still rather be at home, and why not? So life quality issue would also be served well if we can really closely look at this issue.
Well, let's talk about the cost, though, too, how much this is just costing society in general. Correct me if I'm wrong, but the figure I've seen is something like 80% of all Medicaid dollars are spent in nursing homes. So what should individuals be doing differently to prepare for the costs? So maybe they can afford this in-home care.
Well, we were chatting about that before we started this, that, people in our society want to very much leave resources to their families. And we have to take a different mindset at some point in time, that the resources that we have attained need to be utilized to keep us in an environment and take care of us the way we want to be taken care of, not to put that burden back on the government to do that. We have to take that responsibility back. We're a different society. 50 years ago, Grandma and Grandpa came to live with you, they stayed with you, and only at the very end, when you could not provide the care they needed, were they placed into a long-term care facility. But society has changed. Families work, they have children, they're involved, it's a totally different thing. People are not as receptive or able to sustain that in the home. I think the other
part of that is that there are fewer families that are staying in the same area. Most of the children have moved to another area of the country. Even if they're in the same state, they may be 2 hours away. And so being able to provide that day-to-day care is not available.
And I would like to add that, it is a mindset culture which needs to change. We as a society need to take a more proactive role in that. It is such an important part of our future planning which has to be done. Similar like advanced care planning, chronic disease management. I think there's a lot more room for education, and this is a role which primary care physicians can play in their clinics, when they see for your patients when they're younger, for their preventive measures. But there, other than the mindset, there's other things people can do, which I'm seeing now the baby boomers are paying more attention to, is having something like long-term care insurance, so that investing into when you're healthy, because once you have an acute crisis, it's going to be really hard. Is that right?
Very much. You're almost not going to be able to get any long-term care insurance.
And I'm just seeing that there's been a rise in the numbers of people using private insurance for long-term care. I think the numbers are almost around 5% now, as opposed to like 3% a couple decades ago. So there has been some move, but I think we really have to educate our patients when they're younger, when they're more healthier, to really think about investing into. When you're when you're younger, things are going well, one does not really think about these issues. I think it really depends upon the health educators and the physicians, the primary care doctors, to really bring these just very, very complex discussions into the exam room with them.
I believe Indiana ranks really poorly in terms of the number of people who have long-term care insurance. Is it a lack of education, or is it just cost prohibitive?
Well, for many years,
people?
it frankly wasn't promoted, and it really
It's
wasn't
not on the
available.
radar.
It wasn't
No,
something
it
that
certainly
people
wasn't.
talked about.
More on the East Coast, but in the Midwest, it simply was not. Because I can remember going to symposiums 30 years ago, and it just wasn't in this market, but it was in other areas. And no, it's not been on the radar. I think that's very clear. Another point I think, or at least I would like to bring forward for discussion, is I think that often our seniors, if they work with their physicians and they understand what their circumstances are, will want to choose what they want in terms of extended care. The families are not always cooperative with that.
No.
The children will want you to pursue things that perhaps their parents did not want. And I think clarifying that in more of an active role with the attending physicians is critical.
Absolutely.
Because you want to do what the senior wants.
It just falls under the big umbrella of goals of care planning. You exactly want, I mean, as physicians and medical community, we can do a lot for our patients. It's an unlimited menu of options we can pursue, but is it what the senior wants?
Right.
And is it what, and really getting the big extended family on the same page, so when things go haywire or the crisis comes, everybody knows what mom really wanted and can respect that. So I fully agree. This absolutely falls under advanced care planning. You know, do you want to be resuscitated? You know, do you want to be on 50 medications, or do you want to be on tube feedings? And where do you want to live, you know, when you're older, when you're not able to? So it absolutely falls in the realm of the same discussion, absolutely.
And Sharon, when you're having conversation with families of loved ones, how much does cost figure into those discussions?
It is a huge factor. When you approach a family and talk to them about what their loved one is going to need, what might be paid for by Medicare if they have Medicare, what might not be, what might be their out-of-pocket cost. When they start hearing those figures, you just see them completely shut down. Or they look at you and say, there's no way we can't do this.
Yeah, everybody comes with their mind. I mean, people do get shocked because they realize that, you know, we live in the, you know, in the United States of America. We probably will be entitled to all the health care eventually, but they're not just aware that there are certain areas of healthcare where they have to contribute, and this is one big area. And I would just like to, you know, just want to add a thought on that, talking about insurance coverage. I don't know if you have seen that. What I'm seeing as a physician working in skilled nursing facilities, a lot of patients are coming in who have gotten themselves into an Advantage kind of coverage, given away their Medicare, their usual Medicare, and have taken Advantage coverage, which now makes them pay hundreds of dollars a day of copay, so that their skilled nursing care becomes really expensive. And I'm seeing that issue emerge more and more. Have you been seeing that?
I actually have just gotten through a situation with a patient where we wound up keeping her in the hospital for almost 2 weeks trying to work this out. Because not only is it that they have to pay large amounts of money out of pocket, but the pre-certification process is very, very cloudy. Some insurances require a pre-certification and may take 48 hours before you get an answer. Others will say there's no pre-certification. It's all over the map with that.
So that, I mean, and the reason I bring it up is that, you know, it's like, yes, you want to choose an insurance which is going to work for you, but you want to make sure that it's going to also be providing long-term care. Because what I realized from my own patients is that they accepted this offer because they were going to get free hearing aids, and they didn't realize that they were giving up right to long-term care. So I think
the other part of it is that they have difficulty paying for medications on a week-to-week basis, and they can get their medications with a very limited copay. But if they do wind up needing long-term care, then they're paying at minimum $50 a day copay,
which would add up quickly.
Which adds up very quickly. They do that for approximately 10 to 20 days. Then it jumps to $150 a day. And that can go on for up to from day 21 to day 60.
Right. And one of the challenges beyond that then, once they're in the ECF, is the challenge of their insurance and how they will evaluate their progress.
Right.
And they take a much more aggressive role in discontinuing them from coverage, because that's part of the shared cost with that insurance company. And so if they don't progress at a certain point, or say they become ill in the middle and their progress decreases, they will immediately discontinue them from coverage. So the loss of their Medicare has catastrophic consequences on them that they don't really understand, because they see it saved me $75 a month. I save $75 a month by going to these programs.
And in many cases, it's not just the actual person who needs the services we're talking about too. This has implications on if they have a spouse. I mean, I've heard cases where people have perhaps, you know, lost their house, but I think there are protections now with that, right? Am I correct in that?
Medicaid has a system that the spouse is not dispossessed in Indiana.
But this is something that can take all of someone's assets pretty quickly.
And then the important thing to remember is the 5-year rule that before you set up your Medicaid, you can gift your house or your assets to somebody, but it cannot be within the 5 years of you applying Medicaid, because then you're not allowed to get Medicaid if you gifted away some part of your assets. So,
but that's if you have time to prepare. If you have something suddenly happen to you.
It again falls into
you're finding
you have to be
more and more people do that. And there's a real move of that. In fact, there are specialty attorneys that specialize in that and are out there and help people get that done. More and more people, if you watch television, you'll see them advertise. More and more people are looking at that and taking that approach to plan their estates, where then the burden later would fall upon the state rather than them utilizing their own resources to take care of themselves. And that presents a problem then for, you know, our society as a rule. I mean, I'm not saying it's right or wrong, it just is a reality that it happens.
But I was going to add is that there is light at the end of the tunnel. We are seeing some benefits of the acute, the ACO model or the accountable care organization. You know, again, there's going to be a whole debate about the pros and cons of the acute care, accountable care organization. But one benefit which I've seen as a physician is that hospitals and nursing homes in general are focusing more on quality. There's more accountability for physicians. There's more accountability for systems. And I've seen that are now that the hospital administrators are building more systems to make sure that they take care of the whole episode of care, not just the patient's 30 days or 10 days while the patient is in the hospital. They are making sure that patient is doing well, not just in the hospital, but also the nursing home, and by the time they get home that they have some resources.
Unfortunately, we are out of time. I apologize, we couldn't get to more, but we'll have a lot more on our website. That is our show for tonight. My thanks to our panel of experts for joining us. Send us your questions for next month's conversation at infocus@indiana.edu. You can also leave a comment or see the full video of this show by visiting our website at indianapublicmedia.org/infocus. Thanks also to all of you for watching and listening. Have a great night.
Production support for this episode of In Focus is provided by Hoosier Energy, providing electricity to Central and Southern Indiana electric cooperatives and their member customers. Information at HEPN.com. Beltrace, providing a variety of residential options, including independent and assisted living, and complete health care for seniors through every stage of life. Beltrace, exceptional care, extraordinary caring. And by WTIU members. Thank you.